I'm Carmen Puliafito, and I'm here tonight with Dr. David Boyer of the Retina Vitreous Associates Group in Los Angeles and the Keck School of Medicine of the University of Southern California. And we're going to talk about his presentation at the Angiogenesis 2021 virtual meeting. Dave, happy to have you here. Welcome to Retina Synthesis.
Thank you, Carmen, for having me here. I'm looking forward to seeing further episodes on your podcast.
You gave a very interesting presentation on the use of retinal progenitor cells for the treatment of retinitis pigmentosa. Can you briefly summarize what the study was about and your key findings?
Certainly, as everybody in the audience is aware, we do not have any treatments currently for retinitis pigmentosa. And this is using progenitor cells to treat patients with retinitis pigmentosa with the hope of improving vision and improving visual fields. It is a study we've done. This was a phase 2 study, and we took patients and divided them into 3 categories. We took all comers. We did not differentiate based upon the clinical picture or the genetics. So all comers were enrolled. They were enrolled into 3 groups: 3 million cells, 6 million cells, or a control group. And just to reiterate, these were regenerative cells. These are not something that's replacing. We're not resurrecting the dead, but we're able to, through different ICAMs and different neurochemicals, to be able to enhance some of the cells that are still living to give a better result. So the patients were divided. Were about 27 patients in each group. There were a couple eliminated because they received the wrong dose. But we had a very significant group, almost 25 in each group. And when we looked at the overall group, we found that there was about a 4-letter improvement from the sham group to the 6 million group. And we found that there was some improvement both in the mobility testing, visual field testing, and the VFQ. There was not a significant difference. 4 letters is great, but it's not enough really to go forward. But when we started analyzing the previous literature, a lot of which had been done by Janet Sunnis, we started to look at patients who had visual fields less than 12 degrees, and found that the literature certainly supports not enrolling those patients in future trials based upon the fact they can't really fixate that well. And then we also looked at patients who have 3 lines less vision in the eye we were treating, and there was some form of not amblyopia because but some form of decrease in vision that wasn't able to be improved, and this has been shown in the literature. So we took these 2 parameters and started looking at the patients again. And if you took all the patients and used these criteria, you suddenly got a major improvement. You got 16 letters of improvement and an improvement in all the secondaries, the VFQ, the visual fields, the low luminance maze, and it was very significant. So further analysis was done through the Cole Eye Clinic to try to identify patients who could get a bigger improvement. And when we started looking at these patients, we found that the OSIS thickness was very important, and that the general thickness in the foveal area itself was also extremely important. And when you put those 2 in, you are identifying the group of patients that in the future in a phase 3 trial will be tested. So I think that, the take-home message was for me that we have the ability, at least in RP, to enhance vision and visual fields. And in a certain group of patients who have not gone on to going too far down that, we can't get the cells to be reactivated. And point in time, I'm very hopeful that this product will be available in the future, that it will show in phase 3 trials to be as beneficial as it was in the phase 2.
Where are the retinal progenitor cells from? How are they derived?
They come from fetuses. They are then grown and they go through a manufacturing process. One of the reasons there were only 2 centers that could do this was at the time, these were done for the University of California in Irvine, and you had to be within a couple of hours of the ability to deliver the cells. So Barry Cooperman at the University of California in Irvine, myself at Retina Vitreous, were the 2 sites. We did have patients coming from the East Coast through the courtesy of Jeff Heyer, who was able to follow the patients post treatment, but all the cells were administered at the site. And the cells came from Northern California. They were not at UCI, but the cells were sent there, cryo-freezed, and then grown, and then going through a series of washings to get the final product.
And how were they delivered?
They came to us, in a syringe to be able to inject it directly. This is an intravitreal injection done in the office. We didn't have a hood. We didn't have to, dress. We just gave a standard intravitreal injection, 1 injection, and these results were at the 1-year level. We're currently undergoing additional treatment. We're now retreating some patients to see if there is any immunologic response. Do we get an antigen antibody reaction? So far, there hasn't been any, but it's too early to really determine that. So I'm, very hopeful that this may be something that lasts a year, 2 years, or we may have to give this injection, periodically to continue to boost the cells.
Did you see any structural changes on the OCTs?
We didn't see, we saw structural changes that the Cole Eye Clinic identified through proprietary software of who would benefit. But at this time, we don't have enough information that shows that there was an increased thickness of, the central foveal thickness or an increase in the OS-IS junction. But we can identify which patients seem to benefit the most. And with these on-block, on-FOS OCT images, we can actually look at it and see the easy zones. And really, you can definitely determine based upon that which patients should have a marked improvement in their visual fields and their vision.
Is there any potential application of this in dry macular degeneration?
Well, I do believe that dry will be the next front that we'll try to conquer. I think this should, based upon what we're seeing, should take cells that that are senescent and make them alive. We've seen this with integrins now. We've seen it with other things. Stealth using cardiolipin enhancer of mitochondria also showed it. So I think that we will be able to, for dry AMD, to have something that will enhance these cells and hopefully prevent them from going on to apoptosis.
Well, thank you so much, Dave. This was an excellent session and some exciting work that hopefully will give hope to patients that have been looking for hope for a long time.
No, I agree with you. I hope it works.
Thank you.
Take care.